an amalgamation of clinical and public health, which is so very important because 30% of pediatrics is preventive and social medicine. And he's a scientist and a deputy director. Please come onto the stage. And he will be speaking on the acceptability of complement-directed microbiota for the MAM children, that is moderate acute malnutrition, pre-concept study. And I think it would be interesting as a clinical setup.
Thank you, Professor, for introducing me. Is my slides visible? Okay. Thank you, Professor Ganguly and Dr. Nija, for inviting me here. So I am from Society for Applied Studies, Delhi. It's a not-for-profit research organization. It's a ICMR Collaborating Center of Excellence. We are working in the field of maternal child health for the last 20 years in Delhi. And I'm here presenting on behalf of a group. This is a multicentric randomized control trial, which we have conducted in 3 sites, at SAS Delhi, at CMC Vellore, and at KEM Pune. And so as you all know, acute malnutrition in children is associated with high risk of infection and death and has long-term adverse consequences. In India, 19.3% of the children are wasted, 12% being moderate acute malnutrition, and 7 to 8% being SAM. In India, as somebody has already pointed out today morning, that the treatment efforts are largely focused on SAM children. However, the MAM children, if not treated adequately and timely, can progress into SAM and leads to adverse consequences. So our study was directed at children with MAM, and in this audience, it is well known how microbiome is associated with undernutrition. The mechanism of this study was directed to understand if microbiota-directed complementary foods can improve microbiome maturation and its restoration so that to promote healthy growth and development in the child. This comes from the studies that has been done by Jeff Gordon's team from the Washington University along with ICGDRB, as Professor Kadri was speaking. But in India, as we were doing this study, we have done subtle modifications to that, and we have tried now that in 3 sites. However, the previous studies have not evaluated the effect in children aged 6 to 12 months. We started with children 6 to 12 months because complementary feeding starts at 12 months, and based on our previous surveys that we have done in India, the burden of MAM actually is kind of highest between 10 to 12 months old children, particularly in our setting. So we thought it is important to try this intervention out earlier than 12 months. So we in this study, we have included population from 6 till 18 months of age. Sorry. Next slide. Okay, so this is the pre-proof of concept study. Initially, our thought was to do an efficacy study, but because in India, it is such a diverse population and it's a diverse setting, different populations have different cultural practices, different type of food practices. Before jumping on to the efficacy study, our point was to first do an acceptability and feasibility study in 3 different settings, and then move ahead with the POC study, which we are planning currently. We have included 3 sites. We have not included the eastern part because in Bangladesh, the food habits are pretty similar to that in the eastern part of the country. So therefore, we have included 3 sites. The purpose was to evaluate acceptability and safety of the shelf-stable formulation of MDCF compared to RUSF in Indian children with MAM between 6 months to 18 months at 3 different sites. And then to establish the processes of intervention delivery, specimen collection, transport to demonstrate a feasibility of conducting a larger efficacy trial. So this is open label, age stratified randomized controlled trial conducted in 240 Indian children. 80 children at each sites were randomized to either receive MDCF or RUSF. So at each site, total sample size was 80, 40 and 40 in each group, further stratified into 6 to 12 months and 12 to 18 months. So we have 20, 20, 20, 20 in each group in all of the three sites, a total of 240 children. And based on our protocols, we had to collect the stool specimen within 30 minutes of passage, for which we did the pre-testing. And then we had anthropometric collection at multiple time points, starting from enrollment, then at 2 weeks, time of the randomization. Then again, the treatment phase was of 4 weeks. And during the treatment phase, there was a daily follow-up by our field workers to ensure that the child consumed the microbiota-directed complementary food. So it was a daily 2-time observed feeding, which I will show in the next slides. So this is the composition of the MDCF and RUSF that we used. However, before using the formulation, we have a kind of the previous Bangladesh studies, they used the green banana, the raw green banana, but what we found is that it was across the three sites, there were kind of differences in the type of green banana that is available. However, therefore, we kind of tried to standardize the green banana because that is the essential component of MDCF, and that is a major component of MDCF. So we procured it at CMC, and then we converted into green banana powder using a company, and we dried it, and so that we can use it across in all three sites. And before doing this, we also compared the monosaccharide component of the MDCF and RUSF to be sure that the monosaccharides of the MDCF and RUSF, although we formulated an isocaloric formulation, we tried to ensure that the monosaccharide component of the two formulations are not very close. So we did this experiment in the University of St. Louis in the US, and after that we kind of came up with this formula. We tried to, and MDCF now was prepared freshly every day at each site in the morning before delivery. We prepared fresh, and we had a standardized process of preparing this. We had extensive trainings of how to prepare the MDCF. So we prepared this daily, and then we would dispatch this and conduct directly observed feeding in the community twice daily. And we calculated the duration of feeding and also took account of the leftover food. We ensured that the amount of food that we would be giving covers around 25 to 30% of the daily energy requirement. So accordingly, we modified the doses for 6 to 12 months, and the dose was different for 12 to 18 months. 18 grams twice daily for 6 to 12 months, and 25 grams twice daily for 12 to 18 months. We also did microbiological testings to ensure that there were no contamination or issues during preparation of the MDCF at the study sites as a part of the quality control. So these are some photos of the kitchen where we used to prepare the MDCF, and this is how the MDCF used to look. And these are some photos about how enthusiastically these children were feeding. This is how directly observed feeding were done by our study team members twice daily at their homes in these communities. So we, before jumping to the efficacy trial, we defined what would we mean by a high intervention compliance, a good compliance or a partial compliance. We aimed for a high compliance of more than 80% across the three sites. And by high compliance, we mean that the child consumed more than 50% of the food consumed per day for more than 90% days, that is 25 out of the 28 days of the treatment phase. Outcome assessment was done again by an independent outcome team, which was not involved in intervention delivery, and we assessed acceptability, and then we also assessed the organoleptic properties based on a 7-point head and neck scale. We conducted in-depth interviews, focused discussions to understand the mother's perspective of the MDCF food. And we also measured the anthropometric parameters as mentioned earlier, weight, length, also head circumference and mid upper arm circumference. We recorded all adverse events. So this is how we were doing the stool specimen collections, and in these communities, it's very difficult to do stool specimen collection within 30 minutes of passage. Because this is not a hospital setting, this is in the community. Somebody would give us information by phone, we would basically reach there, as we created a system to reach there, and we stored the stool samples in dry nitrogen cryo shippers so that we can store it fresh then and there, and it directly goes into the dry cryo shippers. And our anthro team, they were all standardized by the WHO growth standards team. So we had a training so that the anthropometry standardization was done as per the WHO standards. All the 3 sites were trained for standardized anthropometry measurements. And this is the flow diagram. So we recruited, we enrolled 240 children, although we screened 3,593 children, out of which around 9% were MAM, and we enrolled 240 children. And you see the follow-up, we completed the follow-up in 92% of the children, the follow-up was completed. So we had very less loss to follow-up. The baseline, this is a small study. So the baseline demographic from a public health intervention trial, this is a small study. And the baseline demographic characteristics are a little imbalanced, if I may say. We generally do not use p-values to compare baseline demographic based on the recent CONSART guidelines. However, the point I want to take note is that if you see in the RUSF group, the daily energy intake, this is a baseline daily energy intake, was already a little higher than that of the children who were ascertained to the MDCF arm. And this was not intentional, but this was a random allocation. We use nose method for randomization and allocation concealment. Of course, the random sequence is generated by the independent statistician. So the overall acceptability was considered to be very high. It is more than 80% for all organoleptic properties, be it the aroma, color, flavor, or texture, and overall liking. However, there was a certain issue related to the texture, particularly for children aged 6 to 12 months. The mother reported that the texture was a little sticky and the children were finding it difficult to eat. However, we came up with solution that they could have milk, mix it with milk or hot water and then give it to the children. So that kind of addressed the issue. And most of the children, more than 80% of the children, mothers reported that the child finished the eating of the food without much issues. Again, the compliance for both the 6 to 12 months, the good thing that we saw that across all the 3 sites, in both the age strata, 6 to 12 months and 12 to 18 months, the compliance were good or high. Particularly for the MDCF, if you see good or high compliance was a little bit higher than the RUSF across both the strata. What we understood from the mothers as that they liked the supplement because they could see that their kids were gaining weight, and they were kind of fond of it. Once they started with the supplement, they were fond of it. But it was the same flavor over a period of 28 days. So some woman complained that it's the same food or the same flavor. So there is scope of further improvement in terms of taste, flavors, and texture. Anthropometry outcomes, I just want to highlight that this study was not powered to detect a change in the WLZ scores, and the sample size was not calculated for this purpose. This was just an acceptability and feasibility study. However, we collected the anthropometric outcomes, and what we saw, remember that all of these children were MAM, right? But at the end of the supplement, in the MDCF group, 53.2% were recovered, whereas in the RUSF group, 41.9% of the children were recovered. So it was a difference of 11% higher recovery in the MDCF group. I have deliberately not calculated this p-values and the 95% CI, because the study was not meant for that. Also, if you see the delta WLZ scores and the weight for age Z scores and the age for AZ scores, it seems that in the MDCF group, if you see the mean difference in the MDCF group, the improvement was a little higher compared to the RUSF group. But again, we cannot comment on the statistical precision. We need a larger study to kind of be able to comment exactly whether it affects the anthropometric outcomes. Feasibility of stool sample collection. So across all the 3 sites, the mean time of stool sample collection was 19 minutes from passage to collection. And this was important for us because now we are doing all the gut microbiome analysis, and this is as per protocol of St. Louis University. We are following the protocol and doing the gut microbiome analysis to ensure that we had to keep the collection time short. Adverse events, nothing. The respiratory tract infections was the most common, followed by the acute gastroenteritis. However, all the cases were self-resolved. It did not need any, there were no severe cases, did not need any additional intervention. So good acceptability, comparable acceptability in both age strata, and the mothers are willing for long-term supplementation. Many actually called us and asked if we can teach them how to make it at home. So we gave them the composition and they tried to make it at home. However, there were some challenges related to close monitoring, multiple home visits required. This is a short study, small sample size. We are now planning for a larger study. In addition to this, we are also doing a healthy cohort where we are following up healthy children, 130 children again at all the 3 sites. And the purpose is to, as you were saying, somebody was saying, can we create a bank of stools for children in this age? So what we are doing here, we are following up a cohort from 4 months to 2 years of age. We are collecting stool samples every month and storing them up for developing a microbiota for age Z score for the Indian population. We are doing it on all the 3 sites. And we are currently planning to do an efficacy trial, which will involve a longer duration of supplementation and a longer duration of follow-up in a larger sample size of children to understand whether we can prevent MAM with this supplementation in our country. Thank you.
Thank you, Dr. Sinha. Interesting talk, pre-proof of concept study. I had a question, basically relating to the composition differences between the two. I mean, you used soya oil in one and you used peanut oil in the other. The second thing is you used jaggery in one and you used sugar in the other. May I ask why?
So regarding the sugar, this is a question that we have faced in many times. So we stuck to the main composition which was developed by the Bangladesh.
It was microbially directed and the other was not microbially directed. Yeah. So does jaggery versus sugar make a difference to microbial directed foods?
So,
and why?
To answer, I don't have answer to that question right now. So what we are doing now is we are trying to do a component-wise analysis to see what how each component acts on the microbiome.
Sorry. So my question is actually trying to understand why that would happen. Because some years ago, I was speaking to a sugar mill owner in Kolhapur. And he said that nowadays the jaggery which comes from the sugar mills is mostly made from liquid glucose. Not the traditional way.
This jaggery was Bangladesh jaggery.
Yeah.
This was a different jaggery. And so this jaggery was not Kolhapur jaggery.
No, so then it will make a difference as to which jaggery we use.
But what was the most different, the fiber content in your food was double that of the Bangladesh. And that's the problem, because you are delivering less protein, because protein ratio is the fiber content or ash content increases, the protein ratio decreases. So you will have to. Is it is on? It looks like. I was saying that protein ratio with the fiber content or ash content should be similar. So they were delivering more protein than the MDCS CF1. And there was one more difference between Tammy's preparation and your preparation. Sometimes perhaps you will do it. In the later part, in Tammy's and Jeffrey Gordon's work, they had added a microbial population in that. In the ready-to-use food, which they were using, they had added a microbial population in that, so that this became an intervention. And so when they, so that was an additional intervention. I hope you will be doing that in the future.
Maybe, sir, but just to say one thing, that the way we kind of developed these foods, MDCF was basically what Tamid's team did, because we had scientists come from their team only to show what they did, and we use exact kind of that same composition. The only difference was that we used a shelf-stable green banana powder instead of the raw banana that they used. The RUSF that we developed, it is kind of developed by a company called Christie Fried Grams in Chennai. And this is because in Chennai already, and we adopted the Tamil Nadu RUSF, which is available. We used that and took an adaptation of, because we tried to look at what kind of RUSF is available in the different sites in India. We did not find a very good formulation available in India, because we had to give something to the children with MAM in the control group. And in the Tamil Nadu program, this was already there. So therefore, we took it from there and made it prepared through the Christie Fried Gram company, which is the one who is supplying the Tamil Nadu health programs also. And we use that as a comparison for our group. The only thing we try to do is that we try to see if the monosaccharide components are not very similar to each other, because then the purpose of the study would be defeated. So that is what we did. But the question that Dr. Ramakrishna asked, why we used, I don't have a clear answer to that. What we are doing is that we are trying to do a component by component analysis to try to see which component kind of helps which promotes which gut microbiota. So that analysis we are currently planning to do.
Refined sugars are undesirable compared to the raw jaggery. So that's why this question was asked. And jaggery may have, because there is a molasses part in that, so they might have a distinct microbial population which may not be in the refined sugar.
Dr. Sinha, another very interesting area is the midday meals, because MDSF and all this costs money. You have to direct it, you have to follow it. Research is out there. But the midday meals are something which are simple. And it's like Banerjee got the Nobel Prize for 600 studies which he has done just with lentil and rice, showing the ones who received and did not receive. So I think being in the public health domain, you could also promote these areas. Only thing is the cleanliness, hygiene, etc., because there can be food poisoning and there has been instances. So you have to be careful. But I think that's an area which should be promoted. It's not being promoted to that extent, especially for the malnourished kids who go to school. And it's worthwhile, especially adding an egg, giving khichdi or giving bananas, in addition. And a sweet maybe because they like sweets, Have you been doing that? Anything on that area?
So this is, because this is children with MAM, what we try to do, this is in addition to what they're getting. So they, in different places.
They get it, okay.
Yeah. And these are preschool children.
Yeah,
these are
preschool,
these are 6 to 18 months.
Right.
Here, there is no school.
Yeah.
So, although for these children also, there's a provision of Anganwadi hot cooked meal. But this is in addition to that.
In addition to that.
Because these are MAM children.
Okay. It has been a very interesting session. I think it's enough food for thought, for research, especially the maternal and the child, giving microbiota-directed food, or be it the Saurabh Datta, which open up vistas in, the milk, the microbiome. He always comes up with mysteries, and then he gives us, food for thought for many, many years. And he has done brilliant work, though it is his own work, and it is really very difficult to do this kind of studies. But anyways, it has been very interesting, and I think it has been a tiring day, and I think it's time to go and enjoy, and just go and enjoy your dinner again. Thank you so much.